Our next session dives into one of the most important areas of asthma research, addressing disparities in care. Dr. Elliot Israel will share key findings from this groundbreaking NIH-funded study and what it means for improving outcomes among underserved populations. Dr. Israel is the Director of Clinical Research in the Division of Pulmonary and Critical Care Medicine and the Gloria M. and Anthony C. Simboli Distinguished Chair in Asthma Research at Brigham and Women's Hospital. He's also a professor of medicine at Harvard Medical School and a leading researcher in asthma treatment innovation. So basically, he's bored a lot. Let's welcome Dr. Israel.
Sharina, thank you so much for that kind introduction, and thank you to the Allergy and Asthma Network for inviting me to speak, and also for our sponsors for sponsoring this. Dr. Tracy and Sharina both really alluded to the fact that there are really disparities in terms of asthma care. And I'm going to talk about and review some of those disparities, but I'm also going to talk about the issues that we have in terms of involving patients who are affected by these disparities in research, since many of the recommendations that come out exclude or don't include adequate numbers of patients who are affected disparately by asthma, and therefore don't really consider the different considerations and the different problems for those patients. So I'm going to be talking about studying asthma. These are my relationships. AstraZeneca, which produces one of the anti-inflammatory reliever therapies. I've consulted for them. Villian also does that. Circassia actually provided the nitric oxide analyzers for the study, and Teva provided the medications for the study that I'm going to be talking about. I'm going to be talking about the disproportionate impact of asthma on Black and Latinx communities. I'm going to talk a little bit about structural racism and factors that may impact and really produce some of those disparities. And then I'm going to talk about our outcomes and experience in the PREPARE study that Sharina referred to, and how we tried to overcome the barriers and what the challenges were in trying to overcome those barriers. So and you've heard some of this before, there's really a disproportionate impact of asthma in Black and Latinx communities. Asthma prevalence is about a third higher in African-American Blacks and is double the rate in Hispanic Latinx patients than it is in Caucasians. Both African-American Blacks and Hispanic Latin patients have double the rates of asthma-related emergency room visits and hospitalizations as Caucasians, and they have 50% higher rates of rehospitalization even after they're seen in the hospital. African-American Blacks experience 2 to 3 times the death rate due to asthma as Caucasians, and it's been very difficult to bring these disparities down. The interventions that people have published on and that have shown work usually are very intensive. They involve lots of nurses and ancillary healthcare people, and that's very hard to support in our current environment. I want to review a little bit about how structural racism and factors and how they interact in terms of producing asthma and allergy. So this confusogram, I'll try to take you through it. And so if we talk about the different determinants of health, there's biology, there's geographic ancestry and origin, there's health behaviors, and then there's racism, institutional, cultural, we'll talk about that. And then there's structural institutions, which can interact with all of these, legal, political, cultural, and economic, which can interact with a predisposition to have asthma and to have allergies. And how do these things interact? Well, there are upstream pathways of structural racism in terms of race and marginalized groups, which results in residential segregation, socioeconomic stresses, and incarceration. Those things can lead to a physical environment, which we know has higher rates of pollutants and environmental hazard exposure. The built environments can be very different for patients who are that we see that are experiencing structural racism. Housing quality and occupations can also be very different, again, than the populations that are frequently included in studies. The social environment, the wealth gap and the financial strain, the neighborhood violence and adverse childhood experiences, all of these can lead to what we call biologic embedding. They can lead to aberrations in the innate and adaptive immune response as a result of these exposures to these pollutants and the environment. The physiological stress response, as I'll show you in a while as well, can also lead to changes in the biology And then chronic psychosocial stress can do that as well, which leads to racial disparities and sometimes a very different type of what we call endotype, or a very different type of cause of the asthma. And if the cause of the asthma or what's really aggravating the asthma is different, then the treatment frequently needs to be different as well. So just as an example, there was a study done in Puerto Rico. Poor diets are associated with increased asthma, and food insecurity and food deserts are more common among Black and Latinx patients. In 2021, 20% of Blacks were food insecure. That was 2 to 3 times the rate that it is in whites. Blacks are 50%, and Latinx patients 30% less likely to have access to a chain supermarket in the places that they live, and less access to fresh foods. And there was a prospective study of Puerto Rican youth comparing those with an unhealthy diet to those with a healthy diet. And what they found was, so the same kids who lived in Puerto Rico, what they found that the ones that had the unhealthy diet had a 2.5 to 3.5 greater risk of asthma, and a 3-fold risk of severe exacerbations in those who had asthma. And how does this actually work? So we talked about structural racism over the life course, and here are 2 examples of how the biology actually can change due to the structural racism factors. Ambient air pollution can actually produce changes in the mucosa of the lung. Those changes in mucosa can result in increased mucus production, increased airway reactivity, and also can change the microbiome. And we're beginning to understand how the microbiome actually can be very different, again, based on your environment. That all results in an altered airway microenvironment, which leads to development of allergy and immune diseases. Physiologic stress, and we talked about how all the things in structural racism, the housing issues, food insecurity issues, financial issues can produce stress, which produce norepinephrine and cortisol. And we now understand that increased production of norepinephrine and cortisol can actually change balance between what we call the T regulatory environment and the TH2 environment. The TH2 environment is one that promotes allergy. T regulatory environment is one that reduces allergies. And we know that these things actually can push more to the TH2, more to that allergic, asthmagenic type of pattern, and also result in microbial dysbiosis. So what % of patients with asthma adhere to their inhaled corticosteroids?
All right, everyone get your answers in. That includes all of you joining us online as well. Okay, give it another second. We'll wait till we get to about 80 folks. Okay, Dr. Israel, this is what we have. Rising to the top, we have B, 25%. And then, excuse me, for answer B, 55% of our attendees chose answer B. 25% of our attendees chose answer A. 17% chose answer C, and 4% D.
All right. Well, the majority got it right, but still, a lot of people. It's 25%. When you look at, we're going to talk about this. So we know that inhaled corticosteroids are really among the most effective therapies, the most effective therapies that we have in terms of treating asthma. And while inhaled corticosteroids are the cornerstone of asthma control therapy, adherence to them is low. It's 25%. When you look at people who have a chronic inhaled corticosteroid prescription, and you look at the refills, they only refill 25% of what they should be. And so 25% is probably high, because even when you refill, that doesn't mean you're necessarily using your medications. Sorry? Is it better or worse for kids? Well, the refill rate is a little bit better because the parents refill, but it's not quite clear whether the kids take it and how they do it. So the data show that as needed inhaled corticosteroids, and this was referred to early on by prior speakers, guided by asthma symptom triggered beta agonist use can improve asthma outcomes. And we call that anti-inflammatory reliever therapy. And the thing about that, normally what we used to say to patients is you have to take your inhaled corticosteroids twice a day. Don't use them when you have symptoms. Use a reliever when you have symptoms. But this actually is patient empowering. It's actually much easier in terms of describing to patients what they need to do. So it's a low burden on providers. And when we've talked to patient partners, they always say this makes a lot more sense to us. And this is frankly kind of what we do, but we're not quite sure how we're supposed to do it. And this has led to what was referred to before as what's now called MART, maintenance and reliever therapy. So multiple studies in moderate to severe asthma have shown that using inhaled corticosteroid and formoterol is a long-acting beta agonist or a long-acting reliever, but that has pretty fast onset of action. So it's commonly known as Symbicort or Brena. And also Dulera, which has inhaled corticosteroid and formoterol in it as well, as maintenance and reliever, reduces asthma exacerbations as compared with using maintenance alone. And population-weighted combinations of these studies show that the reduction in exacerbations is about 0.12 exacerbations per year. The reason I'm telling you that is I'm going to show you other data that compares to that. And there's variable outcome in terms of asthma control. And the average number of extra inhalers that gets used when you compare the people who are using regular and reliever albuterol versus regular and as needed ICS formoterol is about 4 extra canisters a year. And MART, as was pointed out by Dr. Tracy, has been endorsed by the NAPP, the National Asthma Education Program, and the Global Initiative for Asthma for moderate and moderate severe asthma, and now actually is also being endorsed for mild asthma as well. So there are problems, though. So you'd say, oh, this makes a lot of sense. You just tell patients to use their medication twice a day and just use it as needed. But there are problems. First of all, if you use a nebulizer for your reliever therapy, then you can't activate MART, right? It's not that you're not using the inhaler for relief. And so all the studies that were done with MART therapy excluded patients who were using a nebulizer. It turns out, again, there's a disparate effect here, that there's much higher use of nebulizers in Black and Latinx populations, in populations that don't have as much financial resources. A lot of the Medicaid programs really push people toward nebulizer use because it's much, much less expensive than the branded relievers. So it doesn't activate, and so the patient doesn't receive the extra inhaled corticosteroid. The other problem is that while we're all encouraging patients to do this, the FDA is not signed on to this. The reason the FDA hasn't signed on to this is all the studies that were done with ICS formoterol were done with a formulation that does not exist in the United States. And so the FDA said, you haven't tested it with what you're selling here in the United States, and therefore we're not going to give you approval to do that, to say that you can do this here in the United States. The effect of that is that a lot of insurers, oh, no, no, no. This is not, I look in the package insert, my regulatory people say, we're not going to pay for this because this is not approved by the FDA. So they won't cover inhaled corticosteroid inhalers each month. The other part of this is that for patients, you finally get the patient to kind of do what you want. And then you're now saying, well, I'm going to switch everything around here. And I'm going to take the medications that you're used to and that you know, and I'm going to give you these other medications. That's a barrier as well. The other piece is that as I mentioned to you, these reduce exacerbations, but don't appear to have significant symptoms. So there's another approach that we tested in the study that I'm going to describe to you, which was PREPARE, and we call that approach PARTIX, which is a patient-activated reliever and triggered inhaled corticosteroid. And we tell patients how to use their inhaled corticosteroid that they already have every time they use their reliever medication. And this artificial intelligence picture kind of shows what we do, which is we tell patients to take a rubber band and to take their inhaled corticosteroid inhaler and to take their albuterol inhaler, and they can nest them. So this is showing when it's unnested. You turn them around and use one and then use the other. And then when you're finished, you turn them around and they nest in each other. In many cases, that works for most of the common inhalers. And we tell them to use it puff for puff every time they use their albuterol. They should turn it around and also use their inhaled corticosteroid. The nice thing about this is we can also say, every time you use your nebulizer, we want you to take the inhaled corticosteroid. And we told patients to take 5 puffs of the inhaled corticosteroid because a nebulizer is equivalent to 5 to 10 puffs or more of the albuterol. And when we talked to patients about this, patients said that they felt that this was patient empowering, that they felt a lot, we talked about the adolescents and adolescent males. And for many of us, we're at war with our chronic diseases, right? We know we have them, but we don't want to have them, and we want to resist. And so a lot of patients want to resist. But this is one that's patient empowering. This says you're in control. You use the medication when you feel you need it. And they felt that that was actually a big advantage as well. And the fact that there was no need to change the medications. So PCORI, the Patient-Centered Outcome Research Institute, is actually the funder who funded this study, which is called PREPARE. Based on discussions with patients, providers, and advocacy groups, we hypothesized that Pardix would improve asthma outcomes that were important to patients in the healthcare system. And based on discussions with these partners, we decided to look at 3 outcomes. We decided to look at exacerbations, which patients said were really a big part of what the impact was of their asthma. These were things that caused them to miss days from work, lose their jobs, miss days from school, as somebody mentioned, have problems with completing their semesters, getting incompletes. We talked about asthma control, and then people felt it was very important for us to monitor days lost from work, school, or interfering with the activities of daily living. So it was basically a fairly simple study. We enrolled about 600 African-American Blacks and 600 Hispanic Latinx patients, and we randomized them to either go on with their usual care or telling them, here, use your inhaled corticosteroid. These are the instructions for you. Use your inhaled corticosteroid. Every time you use your albuterol, put a rubber band around, or we gave them a Velcro. We said you can use that or use your rubber band. And then we followed them out for 15 months. It was one set of instructions. That was it. And then patients got a monthly survey to understand what they were doing. We recruited 1,200 patients. And there was 90% survey completion, which any of you who've done studies know that that's just really kind of amazing. So patients really got into this, and we only had 4% data loss. So patients really, really, and I'll talk to you a little bit about why in just a minute. And what we showed was, hey, this really does work. The hazard ratio is 0.846. We reduced the exacerbations by 0.13 exacerbations per year. And we published this in the New England Journal of Medicine. But remember, what I told you was that MART reduced exacerbations by 0.12 patients per year. So this wasn't a flimsy rate in terms of reduction of exacerbations. Even more importantly, I told you MART excluded patients who are on nebulizers, but MART did another thing. MART only took people who had an exacerbation in the prior year. We took people who actually either had an exacerbation in the past year or who were poorly controlled, even if they hadn't had an exacerbation in the prior year. And as Dr. Tracy showed you before, one of the biggest predictors of having a subsequent exacerbation is a prior exacerbation. So MART studies really enriched for people who were going to have exacerbations, but we did not. And if we restricted ourselves to the 75% of patients who told us they'd had an exacerbation, then the reduction was 0.21 exacerbations per year. So this was highly effective for this group of patients. We also showed, remember that our patient partners told us that they wanted to see asthma control. We showed that there was an improvement in asthma control. This is the asthma control test. The blue is the patients who got the Pardix. The red is the patients who did not. And then in terms of days, quality of life and days lost from work or school. This is again quality of life. Again, you see the blues that did quite a bit better, significantly better. And in terms of days lost from work or school, there was a 20% reduction in terms of days lost from work or school or ability to do this. The other thing is that Pardix reduced reliever therapy. So monthly, we asked patients, did you renew your albuterol? We also asked them, did you use your nebulizer this month? And what we found was that there was about a 20% reduction in patients refilling their albuterol, which we know again is another indicator of patients at risk in terms of asthma exacerbations. And there was a 1/3 reduction in the use of nebulizers as well. The other thing is, remember, I told you that for March, there's a 4 canister increase per year. When we looked at total use of inhaled corticosteroid medications, there was only a 1.1 increase in the total increased use of asthma medications. So this actually turned out to be less of a burden in terms of economics in the healthcare system. And remember, the SMART average is about 4.5 per year. So the study, though, so we enrolled a population people normally say is really hard to enroll, really hard to get to participate, really hard to get to continue to participate in a study. So why did this work, and what can we learn about trying to really include patients who really need to be included in studies so we can generalize the findings that we have? So why is it difficult? There's a fear that patients in these marginalized populations are guinea pigs for interventions that are going to be used for other groups, that they're being studied, but the medications are going to be used for somebody else. There's a legacy of mistreatment in studies. That's many of you are aware, the Tuskegee studies where patients were allowed to have syphilis and weren't and didn't receive any treatment, even though there was treatment. So how did we get there? I think primarily one of the biggest things we did is we involved patient partners. I've referred to them repeatedly, but these were advisors from study inception. They were responsible for thinking about our study design. They were responsible for thinking about how we were going to implement this. They were responsible for what we were going to use as outcomes. And so they made these outcomes, they made that study important to the people who were going to be in the study. So we had 17 advisors, and they emphasized to us the following things. You need to, in the educational materials and the videos you put together, you need to use people who look like us. So that meant that we had to create things for Hispanic Latinx patients. We had to create things for African-American Black patients. You need to approach practices that treat us. We have relationships with healthcare providers, and those are the people that we trust. Those are the people that when somebody says, do you want to be in a study? If that's somebody I have a relationship with, then I have less fear of being in that, and then I'm being taken advantage of. They kept on talking about simplifying the messages. Every time we came back and they said, no, you need to make it simpler. And then, no, you need to make it simpler. They said, and they said things like, oh, you had our IRBs require a certified Spanish translator. And they said, this is baloney. This is not the way we talk. Right? So again, and we had a little argument with the IRB about that translation. They emphasize the fact that patients need to feel valued. And so adequate payment for survey completion. So we paid people every time they filled out a survey. They got within 24 hours, they got a payment on a card that we had given them. And that was another point that they emphasized, immediate payment for survey completion. We sent out appreciation notes on Thanksgiving and the holidays. And the first 3 rules of the study: KISS, keep it simple, keep it simple, keep it simple. And the last S is stupid. Because we were stupid, but we learned how to keep it simple. And the patient advisors reviewed all of our patient-facing material. So you can say, okay, great, I'm going to get patient advisors. But that's not so easy. That actually takes work. And I'm not talking about finding the people. I'm talking about really integrating those people and making sure that they are really part of your study. So the majority of the patients advisors had no research background. Most of the research team and the stakeholders from our professional groups had not worked with patient advisors. And we had to also, because we wanted to be sure that we were representative of our Spanish population, we had 2 people who only spoke Spanish, right? So we needed to think about how we really included all these patients. So we actually ended up hiring a dedicated and professional engagement personnel as part of the operations team. We had 1 full-time bilingual engagement project manager. We had a part-time asthma educator who worked in the community with patient advisors, and as a consultant nurse leader with patient experience and patient advisory councils. We realized that after our first meeting, which was a disaster, where the patient partners, even though they were supposed to be, we had 7 tables and we had breakout groups, and the patient partners were supposed to be distributed at each of the tables. The patient partners all sat in one corner. And they said, oh, one of us isn't feeling well and we want to be supportive. And so I said, okay. All right, we need to go back to the drawing boards, right? And so what we realized was that while we thought we had done a good job, we really needed to work on educating the patient partners about what was really going to be happening at the meeting so that they really felt comfortable. We know we wanted to include them, but if they really didn't feel comfortable, they weren't going to allow themselves to be included. So we actually then worked on education of the patient partners in terms of study design principles and statistics. And what we actually did is then, before each meeting, there was a pre-meeting with the patient partners where we went through the full agenda and what was going to be discussed at those meetings, so that they felt that they were really coming in at the same level as the other participants. We also compensated these patients at the level of consultants. So everybody, the physicians, the advocacy advisors, all of them got paid at the same rate. This was again another point of saying, I'm valued. What I have to say is as valuable as anybody else. There was continuous involvement in decisions of study design. All were invited to the yearly meetings. We had pre-meetings, as I mentioned, and the patient partners were, after that first one, did participate and were embedded at each table and each breakdown. They were on all the committees that we had, including there was a patient partner representative on the executive committee as well. There were 2 calls each month. So again, continuous involvement. So it wasn't kind of like you hear from us and you don't hear from us again for another 6 or 9 months. The in-person meetings and the on-call meetings included a translator, and all materials were in English and Spanish. And the other piece is that we gave them feedback on every suggestion they made. So one of the, I think, most disempowering things is you put your effort in, you make suggestions, and people say, that's great, and then you never hear anything about it again. And so we came back to the patient partners and we said, these are the things you said. This is what we did. And it didn't mean that we always were able to do what they suggested, but we explained what we did. And when we couldn't do what they had suggested, we said, we couldn't do this. This is why we couldn't do this. It was a good suggestion. It made sense, but we can't do this either for regulatory reasons or for study design reasons. And this is why. So like when they had made suggestions about changing wording in parts of the consent form that were controlled by the IRB, there are certain battles you can win with the IRB, and there's certain battles you cannot win with the IRB. So, and changes to standardized questionnaires, which had been validated. And again, it was a teaching process and a learning process in terms of understanding what a validated questionnaire was. So I think that was, and when we did debriefs with the patient partners, one of the consistent things that came through was I felt respected and I felt valued. And that was, so I think that's again, but it is not an easy thing. It's not something that, oh, I respect you and I value you. You need to demonstrate that repeatedly through your actions and what you do. I want to show you a little bit more about what we've learned. So this is a analysis that Juan Carlos Cardet, one of my colleagues, did on the data from the PREPARE study. And what we looked at was what things contribute to hospitalizations. And it turns out that, as I talked about, these socioeconomic factors contribute to hospitalizations, and actually low socioeconomic status was directly associated with hospitalizations and worse ACT scores. And when we looked at mediation analysis, stress partially mediated the relationship between the socioeconomic status and the ER and urgent care visits and worse asthma control. So these things are real. They really do make a difference. To summarize, Black and Latinx patients really bear a disproportionate burden of asthma. The causes are there are a lot of different causes, and they include interactions between biological susceptibilities and factors induced by structural racism and socioeconomic determinants of health. Despite historical reluctance of underserved populations to participate in research, you can involve members of the community, and by doing that, you can dramatically increase the participation of those patients. And a patient-empowered Part strategy can reduce asthma exacerbations in this population and can be maybe more accessible than SMART and possibly as or more effective, especially nebulizer users. And PCORI, which funded the initial PAIR study, has now agreed to fund what we now call the iCare study. And I want you all to go out and tell patients to enroll in this. So we got a PCORI Placer grant to directly compare Part to MART, because we had just really shown that Part worked. We didn't show how effective or how different it would be in MART. And so this is a really large study. It's 4,000 patients because we're now comparing 2 effective therapies. So nobody's being a guinea pig in this study. Everybody's getting an effective therapy. These are patients who are not on anti-inflammatory reliever therapy. And we are saying we have anti-inflammatory reliever therapy for you. And there are 2 different flavors of this. And we're trying to figure out which flavor might be better for which type of patient. And that's why this is good for you. Either way, we're going to improve your outcomes for you. But we want to try to figure this out. And in PREPARE, about 50% of patients use nebulizer once a week or more. We know that patients in government health programs tend to use nebulizers more than private insurance. And now, unfortunately, with the changes we're seeing in coverage, we may see even more of that. and we know that there's a lot of nebulizer use. So we're looking at both of this. I want to acknowledge all the different groups that made the PREPARE study, and many of whom are continuing, our co-investigators, our Brigham study staff, our patient partner stakeholders, our patient advocacy stakeholders, and our professional society stakeholders. And our study site investigators and our study site staff really made this study happen. And the health policy experts and the coordinators from the American Academy of Family Physicians and the expert scientific advisors. Thank you very much.
Thank you so much, Dr. Israel. I geeked out on that.
Oh.
I see that others in the room as well. We have some time for just a couple of questions. I know you have many. I'm going to start with one online, and then I'll do a couple in the room as well. So the first question that we have here online is, question on the PREPARE study: why weren't spacers used?
Oh, okay. Well, first of all, I think we wanted to make this as realistic as possible. And yes, patients get spacers, but they don't use them. And so we didn't stop people from using spacers. We just said, here's the inhaled corticosteroid. If you want to use a spacer, that's great. If you don't want to use a spacer, that's great too.
So, thank you. Let's go over here in the room. Online, I haven't forgotten about you. I'll get to you next.
Hello, Dr. Israel. My name is Jerry Pinto. I'm coming from Melbourne, Florida with Optimal Research. I'm a pulmonologist, and I have a question. For this particular study, what was your definition of Hispanic, Latin, and Latinx? And did that make a difference in the results?
So patients were self-identified. We took patients however they wanted it. Again, this is supposed to be a real world study. And so if you're treating a population group, you're not going to sit there and say, I'm going to do genetics, or I'm going to ask you who your father was and who your mother was and where they came from. If that's how you identified, we wanted to make this, again, real world, so that you could try to say, okay, when patients come into my office and they say this is the group that they belong to, what, are there differences between those groups?
So as a result of that division of definitions, did you find any difference between Latins, Latinx, or Hispanics?
Yes, we did. We did. So we found in another publication that we put out, we looked at patients who came from Puerto Rico, patients who came from the islands, and patients who came from Mexico and South America. And the patients who came from Puerto Rico and the islands actually had worse asthma and did worse.
Great question. Take online, and then Linda. Yes.
So when dealing with different cultures, how are you managing the concept of I only take medicine when I'm sick? I don't take it as a controller.
So I think this is, again, what real world studies are about. So we take patients where they are. And so, we recommend that, in this population of patients who are using, who've had exacerbations or are poorly controlled, that they use their medications twice a day. But as you can see, as I showed you, they only renew 25% of the time. So we know they're not doing that. But again, that's what real world studies are about. You want to make sure that you meet patients where they are, as opposed to saying where they should be, but not being able to get them to where they should be. And that's why I think this was so powerful, in the sense that we showed in that group, we took everybody where they were, and that we could really improve outcomes for them. And we knew, and, I didn't have time, but, we saw what was happening was that patients were renewing their regular inhaled corticosteroids even less when they went on Pardix, because they felt so much better.
Dr. Israel, I've been a long admirer of your work, and I just am so grateful that you came here today to talk about the PREPARE study. I know it was funded by PCORI, and I just wanted to let everybody in here know that one of the reasons why we have Dr. Israel here today is that we wanted to spread the word about the fact that PCORI has something called evidence updates on the PCORI website about the PREPARE study and the key findings. And there is a version of it available for patients, that's written at a lower reading level that's easier to understand in lay language. And then there's one for the clinicians with references to the literature and all that kind of stuff. We will include that in the follow-up email that we will send out. But if you just wanted to go to the PCORI website, you could find it. So I just wanted to let you know. One other thing I just want to mention is if you were listening or participating last year when we were in Boston, Mary White was the speaker at, I believe, lunch, who talked about her experience as a community health worker, but also she's one of your patient partners.
Yes, yes. Mary was one of our patient partners. Yeah.
Oh, she is. Mary, we love you. Thank you for joining us again here today.
We love Mary too.
very
And
special lady.
I will say, to talk about this placer study. So 4,000 patients is a lot of patients. It's really a ton of patients. We are thinking about how to involve and recruit patients. And we're thinking about, for instance, social media. The difference between the PREPARE study, the PREPARE study had one face-to-face visit, and then everything else was remote. We are making the eye care study totally remote. So you can be enrolled, you can be in Nebraska, and you can enroll and be on this. But any thoughts of how to involve patients and communities? We're all ears because this is an uphill battle, and the success of that study depends on including those patients. And I think it's going to be really important to understand what the different options are for patients. So thanks so much. Oh.
Yes, good afternoon, good morning, I guess, because I see the lunch sign there, so
I'm
get me
between you
dis-
and lunch.
get me distracted for all my questions. But my name is Rosa Garcia. I'm coming from California. I'm an asthma coordinator. I've been educator for 26 years. So when I hear things today, it just comes to us as part of all this process because education is mainly priority behind the provider, behind the specialist, right? Because not saying in a bad way, but you can be able only spend 50 minutes with a patient when we can sitting with them. So the way I see it, it's to have a patient to be actually under control and follow all the rules. It's hard as the system. It's not working as everybody on the same boat. My experience is because now when we got the GINA guidelines, we start like reinforcing them so good because it's only two of us for 10 clinics. We're covering 10 clinics with that education. And then reinforcing the guidelines, it wasn't easy because I have to work not only with my patients, but I have to also work with the providers. And I get to one point that I have to work with the pharmacist, if anyone is here, with my respect. I have to deal with the pharmacist when a provider is prescribing a smart therapy and they don't process the prescription, not because of the coverage. It's just they're not familiar with the new treatment, and I have to call the pharmacy and then teach the pharmacist what is the new treatment for this patient that it's, as we learn, is better now, right? So it's like it's a big process that everybody should be like educated. We're going back to the same spot, educated on the same topic that everybody's working on it. When we get a patient and we start like explaining them about, oh, it's not 2 inhalers anymore, it's just one, and you can use it in both, situations. And then it comes that the specialist is totally prescribing as the old-fashioned way. So it's hard for us as educators. So I'm just want to bring that up. For spacers, when you say, oh, it's okay, they can use it or not use it, it's hard for us as educators because we're kind of reinforcing all the time. And we hear that, oh, with the spacer, you get more particles of the medication and all the stuff, right? So, and the follow-up with the patients, that's another thing too. So we have a QI in our clinics, and then we get together every month. And we're trying to see how we can improve as a team, as a work. So like the study that you're doing, we're actually probably doing a study every single day in the clinics, right? And then we bring that up on the meetings. But it's just not easy when we're trying to do one thing and then the other part of the system is doing something totally different than what we do. Nebulizers, right? We reinforcing on my part. I don't know if I'm wrong, but the teaching that we had is that at this point, we're still trying not to use nebulizers because of the COVID situation and all the viruses right now, especially with the season coming for us in California for the weather. And all the viruses. So it's like trying to avoid as much as you can the nebulizer. Just use your spacer and your inhaler because it's safer to get any other virus in your lungs directly because you're breathing in. So all the stuff, it makes us like thinking, okay, are we doing, so I just bring that out.
So you're doing God's work. So thank you. And so, and this is all about implementation. And I think my experience is, so I see patients and I say, I don't want you to use a nebulizer. You really shouldn't use a nebulizer. You can take a whole bunch of, you can take 5 puffs of your albuterol, and that's going to be equivalent to a nebulizer. And then when I see them back the next time, and they say, yes, yes. And then when I see them back the next time, they went to their primary care physician. I stopped the nebulizer. They went back to their primary care physician, and they got the nebulizer from their primary care physician. Patients love their nebulizers. And, so again, we're doing real world. We have to acknowledge what our patients are doing and work with them and make sure that we're addressing what they're doing. We can't pretend that we're only going to address the people who listen to us because then the people who don't are the people who get into trouble, right? And so I think we need to think about how we do that. And so, and that's the same thing with the spacers. It's just an acknowledgement. Best practice is to use a spacer, but people aren't going to carry a spacer in their pocket. That they just don't. And so again, while we said you should do it, we know that people aren't, and that's kind of how that works. But thank you for the work you
Dr.
do.
Israel, we have one last question.
sure.
I know we're ready for lunch. Just one more.
So it's a bit self-interested. So my name's Eric. I'm from Missouri with the CDC's funded asthma program there for 20 plus years. So next week, we begin a bit of a roadshow doing trainings for case managers inside community health centers, right? So these are mostly nurse case managers that are working almost exclusively with kids predominantly, but kids and adults. Everybody is on Medicaid or uninsured. That's the context. So what are your top 2 things you tell the folks that are doing this work every day in terms of care coordination, case management for what is the patient population you described that would be the target of the studies that you did? There's just a lot of information to provide, and we're trying to do our very best to say, like, these are really the 2 things. And what would be your 2 things to tell that group?
So again, and thank you for that work. So I think KISS is the really important piece here, right? So it's either if somebody's on a inhaled corticosteroid for motor oral preparation, it's saying to them, not only use this however you're using it, but use it every time for reliever. Take away your albuterol. And for people who are on inhaled corticosteroid preparation or who are using a nebulizer, rather than trying to convince them, which you can't in a very short period and even in a long period, to get rid of their nebulizers, saying, okay, use your inhaled corticosteroid, put a rubber band around it, and every time you use your albuterol, just flip them. And when you use your nebulizer, take 5 puffs. And, that's a fairly simple story, right? And, kind of addresses both patterns of use. And we learned that it was, as I said, it stuck. It was just one session, and then it was, 15 months afterwards. So it was fairly simple. And we would get notes from patients saying, I just can't believe how much better I'm feeling. I want to write to one person wrote, I want to write to the president and tell him about it. And the other, and so it was really amazing. And when we first did our feasibility study, we actually had monitors on the albuterol rescue, and we could see patients who were using their inhalers 12, 14 times a day reduced to once or twice a week. So it can really be dramatic in terms of the amount of improvement the patients can experience.
Thank you so much, Dr. Israel. Thank you all for your great questions. I think that just ends us on such an important note there. We're going to take a quick break, grab lunch, come back because we do have a very powerful patient story that we will hear during lunch. Thank you. And those of you online, stretch, have your bio breaks, come back in a few minutes to also participate in the lunchtime presentation. Thank you.